name is Dr. Eric Ganz. My pronouns are him, his, and he. Just a little bit about me and where I'm coming from. I've been a OB/GYN for almost 25 years. I work at Mount Sinai, actually Mount Sinai Morningside and Mount Sinai West. I wear many, many different hats here in the Department of Obstetrics and Gynecology and Reproductive Science. And I work for the Institute for Advanced Medicine. And I worked there for many, many years. It's a place for HIV infected and HIV at risk patients. It's a place for everyone to be seen. It's a multi-specialty practice. It has internists, it has cardiologists, it has dental, it has gynecologists, it has many, many different things there as well. So today I just wanted to kind of just talk about gynecology in the HIV infected patient. Being HIV positive and going to the gynecologist should be the exact same thing if you're HIV positive or if you're HIV negative. In today's world, there shouldn't be any real differences. That being said, there are some things that, if you are HIV positive, you should look out for. For the most part, I really want to keep this sort of, if you were going to the doctor and I was trying to explain something, these are the things I really want to touch on. So first of all, what are the differences between being HIV positive and HIV negative overall when going to the gynecologist? And the big things that we all know about are the cervical cancer screening guidelines. They are different if you're HIV positive than you're HIV negative. And what about, is there a difference in the screening for sexually transmitted diseases if you're HIV positive and HIV negative? And if so, what is the difference in the screening? Is there a difference in treatment? What about anal cancer? I mean, we always, it's a very rare cancer, but a lot of people have been tested for it and screened for it. And why are we testing HIV positive patients for this and not HIV negative patients for this? I do want to talk about family planning. There are a lot of patients who are getting pregnant, who want to get pregnant, who want to have a wonderful family. And there are patients who want to plan on pregnancy, people who don't want to get pregnant and want to be on some form of birth control. There are options out there that some are better than others. Some can mix with, your highly active retroviral therapy. Some don't. So I do want to talk about that. I also want to talk about some menstrual disorders, which are common in HIV positive patients. I want to talk about menopause. Big topics. So let's just start with doing the pap smear screening. So the pap smear screening, cervical cancer, right? Most women go to the gynecologist for, and if you ask anybody, they'll go like, well, why are you going to the gynecologist? Oh, to get a pap smear. In today's world, we don't do pap smears as often as we used to. And the reason is that there's the risk of cervical cancer is not as frequent as we thought, and so we don't need to screen as much. That being said, that I do need to let you know that the incidence of cervical cancer is much higher in HIV positive patients. It's almost 2/3 higher in HIV positive patients, but I need to let you know it's still number 30 on the list, right? Colon cancer is number 3, lung cancer is number 1, then breast cancer, then colon cancer. And then way down here is cervical cancer. And the reason why cervical cancer is way down here, really low, is because since the 20th century, we've developed pap smear screening, and that's why. But in places around the world where pap smear screening is not available, cervical cancer is very frequent. So there are studies to show that cervical cancer risk may be related to or inversely related to someone's CD4 count. Someone has a low CD4 count, they may have a higher risk for cervical cancer, and vice versa. If they have a high CD4 count, then they'll have a lower risk for cervical cancer. Cervical cancer also presents 15 years earlier in general than people who are HIV negative, and it also may present at a much more advanced stage than someone who's HIV negative. So let's just talk about what are these screening paradigms. So just to let you know, for people who are HIV negative, the new thing is we don't screen until the age of 21. That's kind of weird, right? We used to, when I was much younger, we used to screen at, much, much earlier than that. But in today's world, we do not screen until the age of 21, no matter what, no matter if the patient had, sex at the age of 14, doesn't matter, at the age of 21 and above. Now, if the person's HIV positive, the recommendation is to start pap smear screening within 1 year of sexuality or 1 year within the diagnosis of HIV. And that's in either case no later than the age of 21. So there's a difference right there. When to end screening for someone who's HIV positive? Well, if you're HIV negative, we end screening at the age of 65, no matter what. If you're HIV positive, we don't end screening at the age of 65. We keep on going. So these are kind of things that are different, and your gynecologist should know these differences and follow them. And there's all these new guidelines that are coming out for routine pap smear screening. But for people who are HIV positive, we don't really follow the new guidelines. We are pretty strict with the old guidelines. And the reason is that they haven't really tested the new guidelines on HIV positive women yet. And so they really want to be careful, and they want to stay with the old guidelines until the new guidelines have been tested on HIV positive women. So what are the old guidelines? Well, that basically everything revolves around the age of 30. So basically, you start testing once the patient comes in, right? You repeat every 12 months. If there's 3 normal pap smears, you space it out every 3 years, and that's it. At the age of 30, you can space it out to every 3 years, but you need to start testing with HPV. So everyone's asking me, what is HPV, right? Everyone hears about it, everyone talks about it. HPV is human papillomavirus. Human papillomavirus is this virus that is very, very common. Everybody has it, okay? So the human papillomavirus, there are 60 different types. It is everywhere. It basically can cause nothing. Some of the types can cause genital warts. Some of the types can possibly cause or progress to cancer. So we use the human papillomavirus typing with a pap smear to help us decide what to do next. When someone says, oh, you have HPV or you have human papillomavirus, people get, oh my God, I have a virus, another virus. I have to do something about it, or I can pass it on. You don't really worry about that because everybody already has it at some point in their lives. It can come and go in a sense. It doesn't really go away. But what do I mean it comes and goes if you never get rid of it? So it actually stays with you for all your life. But like HIV, the viral load of the human papillomavirus, certain types, can be so low that when you test for it, it doesn't pick it up. And unlike, we don't test for the human papilloma's viral load like with HIV, so you don't get a number. It either is negative or it's positive. It's not like a viral load where you get, oh, it's, 1,000 copies, or it's 300,000 copies. So what happens is that you can get a pap smear that is abnormal with HPV positive, and then or HPV 16 positive or HPV 16 negative. It's either negative or positive. They don't give you a viral load. But these are things that can help, not particularly, it helps the gynecologist make the decision whether you can just get another pap smear another year, or it helps the gynecologist say, we need to do another test further to evaluate what's going on the cervix. Because remember, what does the pap smear do? The pap smear doesn't test for cancer, it screens for cervical cancer. What does that mean? What that means is it just looks for cells to say, oh, there's some abnormality here. That's all it says. It means we need to go that you're A-okay, or there's some abnormality here. We need to go to the next step, which is a colposcopy. And what is that? That is the next step, right? In evaluation of the cervix for cervical cancer. You look inside the vagina at the cervix with a microscope, and if there are abnormalities based on what the gynecologist sees, he or she will take a biopsy and send it off to the lab. Now, I can tell you what those biopsies come back as. So remember, here's normal. I'm talking about cervical cancer. Here's normal. Here is low-grade abnormal, high-grade abnormal, and then way up here is cervical cancer. So when someone says, oh my God, I have high-grade abnormality, the next step is cancer. Oh my God, that's terrible. Let me tell you, many, 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 many people have high-grade on their cervix and lived the age of 99 and never, ever, ever developed cervical cancer. That being said, we like to remove it. Why? Because some people will develop and progress very slowly from that high grade to cervical cancer. Some people won't. Some people will just stay there, live their normal lives to the age of 99 and very happy lives. Some people, though, will progress to cervical cancer. So we actually remove those abnormal cells, okay? Those abnormal cells are not cancer, okay? Those are what we call precancer. Precancer is benign, it doesn't do anything. You can live with precancer, you can have normal babies and children and everything. So I just want to get that clear. A lot of people get, oh my God, I have cancer. No, 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 it's precancer. And that doesn't mean anything bad. A lot of people have precancer and live forever without doing any kind of treatment. So I think I've talked a little bit about the cervical cancer. I do want to talk about anal cancer because it's related to it. Anal cancer is sort of like, people are like, why are you testing that on me? I don't have anal sex, right? I never do that kind of stuff. Anal cancer is a very rare cancer. Only 8,000 people a year get anal cancer. Okay, let's put that in perspective. Colon cancer is 180,000 people a year. Okay, 8,000, 180,000. So there's a big difference, right? It's a very rare cancer. So then you're like, well, why are you testing this on me? The reason is this. First of all, anal cancer, although rare, and just so you're aware of, the anus is this far in, and the colon is this far in. People say, oh, I've had my colonoscopy. Okay, the colonoscopy looks at the colon. The colon is completely separate from the anus. Okay, they're attached, but they're completely separate organs. They cause completely separate cancers, completely separate treatment, completely separate everything. So although you've had your colonoscopy, you may need to have your anal pap smear, okay, and to evaluate for anal cancer. And the reason why we test this in HIV positive patients is because HIV positive patients have 27 to about 42 times the risk of developing anal cancer than the average person. So because of this risk, although rare, remember it's a rare cancer, we screen HIV positive patients, men and women, for anal cancer. What is that? And a lot of you have had this, it's a swab in the anus. It's sent off to the lab, just like for this from the cervix. If it's abnormal, then we go on to what we call a high resolution anoscopy, which is very similar to what we called a colposcopy. I look inside the anus with a little scope, okay, through a microscope. And if I see an abnormality, I will take a biopsy and make sure. And again, it comes back either as low grade, high grade, or God forbid, way up here, anal cancer. And like I need to let you know, low grade or high grade doesn't necessarily need to be treated per se. Okay, we don't know if high grade will ever progress to anal cancer. We think it does. So a lot of people recommend treatment or removal of this high grade lesions from the anus. But overall, we just leave it alone and watch it. So that's sort of the anal cancer. Let's talk about some sexually transmitted diseases and what that means. You know, in general, the treatment for STIs is essentially the same if you are HIV negative. No difference. The big difference is the screening for STIs is yearly for the HIV positive population. We test every year, and the reason is that by missing, if we missed an STI in an HIV positive patient, it could lead to worsening of their HIV or worsening of other diseases. So we'd like to treat it if we see it. So what are some of the, like, for example, the treatment for gonorrhea or the treatment for chlamydia is the same if you are HIV negative. The only real difference is in herpes. With herpes, we treat more aggressively in someone who's HIV positive than if someone's HIV negative. And the other thing that we test for is a lot more patients end up getting and this is not an STD at all. It's a yeast infection or bacterial vaginosis or trichomonas. These are infections that, okay, so trichomonas is a sexually transmitted disease, sort of. But bacterial vaginosis and yeast infection are these common infections in the vagina that a lot of women get. HIV positive patients get this more commonly than HIV negative patients. And we actually like to treat them because their patients are much more symptomatic when they have these infections than people who are HIV negative. And also the risk of transmission of HIV from an HIV positive patient to an HIV negative patient is increased in STIs and yeast, bacterial vaginosis, trichomonas if they're not treated. So we'd like to treat these, especially if you're in a relationship that is discordant. So, and discordant and the other person's not on PrEP and things like that. The other thing I want to talk about is contraception. Contraception, a lot of patients want to be on some form of birth control. And basically the same thing. A lot of you are on many, many medications. And, the thought of taking another pill is sort of just kind of burdensome. I get it. And a lot of times taking these pills can interact with some of the HIV medications. I'm not going to go through the list because each birth control pill can interact differently with each of different of your medications. And you just need to make sure that your gynecologist looks at your medication list very particularly if they're going to give you your birth control, because some of the birth control pills can be decreased in efficacy, meaning that with your HIV medications, meaning that the birth control pills won't work as well and you could get pregnant, thinking that you're taking them every day and they're not working well because you're on HIV meds. So, or just the opposite, they can decrease the efficacy of your HIV meds. So you're taking your HIV meds every day thinking you're doing really well, and then you go back to your HIV doctor and you find out, guess what? Your viral load is up. How did this happen? That kind of a thing. So a lot of people like, the long-acting reversible contraceptives, which we call LARC, and those are the IUDs. Those are the implants, what we call Nexplanon, and those are great options. And the reason some of them, what we call like Mirena and things like that, those are very helpful in decreasing bleeding. That's a great option. As we all know, the IUD goes inside the uterus. It's, you know, once it's in, it works. The Mirena IUD or the progesterone IUD is more protective in preventing births or pregnancy than getting your tubes cut and tied. Now, in today's world, we remove people's tubes out. We actually physically take them out of your body. So it's a little bit different in today's world. But in the old days, we used to cut and tie, and so sterilization, obviously, the Mirena IUD was more successful in preventing pregnancy than the old way of doing a bilateral tubal ligation. And this brings me to some preconception care. Like, what is the plan about, like, and then you say, now I want to, I met this great guy, I'm getting married, he's my fiance, I want to, da da da. We're planning to have children for whatever you decide to have, you're wanting to have children, and you get off your contraception. So what are the things you need to think about or your doctor should think about before getting pregnant? Now, HIV should be well controlled, or it should be at the best as where you can be, meaning that you should be on your heart. And then you should look at all the other chronic illnesses that you have, or may have, I should say, right? Like, for example, a lot of people have diabetes. Diabetes in pregnancy is a big deal, okay? It can cause congenital heart abnormalities in the baby. It can cause fetal demise, or what we call it, a miscarriage, or it can cause other birth defects. So we want if you're diabetic, to be very, very well controlled. You may have underlying other hematological diseases or blood diseases. You may have high blood pressure that needs to be controlled. So these are all these things that need to be or should be controlled before getting pregnant. Does that always happen? Absolutely not. I mean, I can tell you a lot of people come in and say, I'm pregnant. And then I say, congratulations. It is what it is, right? And we will make it work. But, but in general, if you can make your pregnancy the best it can be, then that's the best thing. And also to try to be on a prenatal vitamin every day before getting pregnant. And the reason is that by the time you realize you're pregnant, for most people, you've missed a week, right? You missed your period, right? And that's like you're like 5 weeks. You may be 3 weeks pregnant at that point. Well, 3 weeks or almost 4 weeks, the heart has already started to form, has just started to form. So, you really need to, these are critical times that you want to make sure that you are on prenatal vitamins that have enough folic acid. And at 5 to 6 weeks, the neural tube, the spine forms. So you want to make sure that you have enough folic acid to help prevent those abnormalities from happening. Menstrual disorders, a lot of people, and they are more frequent in HIV positive patients. And why is that? HIV in general is an illness of inflammation, just overall inflammation in your body. So what happens is that it can cause just irregularities of your hormones, and the fact that you're on other medications can cause your hormones to be sort of all over the place a little bit. And so what happens is that you can have menstrual irregularities causing you heavy, heavy bleeding, pelvic pain, those kinds of things. And so, we have lots of armamentarium of medications, and birth control pills are the best for that, or some form of hormonal kind of help with that. And of course, there's other surgeries and things like that, which I'm not going to go into, but that can help. Lastly, I just want to touch on menopause. It's really, really important. Menopause happens about 5 years earlier than in HIV negative women. The average American goes into menopause at 50 and a half, plus or minus 5 years. It is related to your mother's side. So, like, if your mom didn't go into menopause until she was 58, well, guess what? You probably won't go into menopause until later on, right? Or if all your female family went into menopause like in their early 40s, well, guess what? That will probably happen to you too. So that's how it kind of follows. But if you're HIV positive, you do go to menopause a little bit earlier. In the old days, we used to offer what we call hormone replacement therapy. It was like given out like candy. We don't do that as much anymore. They thought would treat everything. In today's world, we do offer it. It is the best option for any patient who is early in menopause who have hot flashes. It really works the best. Now, a lot of people can't take it because of high blood pressure, because of smoking, because of cardiac disease, because of this, and this. But if you're a great candidate, taking 1 or 2 years of hormone replacement therapy at the lowest dose will have turned around some women's lives because of hot flashes. Some women's hot flashes are so debilitating that they're unable to sleep, unable to function, unable to get to work because they just wake up in the middle of the night just with this overwhelming hotness and sweating that they get no sleep, and irritability and things like that it can really change someone's life. Is there risks to it? Very, very, very small. But let me just tell you, it's a risk and benefit. And for these women who take it, their lives have changed, right? They can't get to work or they can't function on a daily basis. Part of menopause is also your bone density. Again, we check HIV positive patients' bone density about 10 years earlier. So my patients, I check them like instead of the age of 65, which is a recommendation by the American College of OBGYN for all women, I check it at the age of 55 in HIV positive women. Because again, your bone density, HIV increases inflammation, which increases your risk of bone loss. And that's what happens with HIV and bone loss.
How do you know when you're definitely in menopause?
Great question. So, a lot of gynecologists use sort of the clinical kind of factor to decide that. if the definition by the American College of OBGYN is defined as no period for 12 months with clinical symptoms of hot flashes and other menopausal symptoms around the average age of 50. So, and no other reasoning for the lack of periods, like, for example, that you're not pregnant at the age of 50 or like something like that. So that's how you would know. Now, we can also test in your blood if there's a question chemically. We can test for what we call follicle stimulating hormone, and if that's elevated, we can say that you're in menopause. But we usually like to say 12 months. But it's not like a switch where you go, oh, you're in menopause, you're not in menopause. It's a gradual slope.
Okay, does the hot flashes ever go away?
Yes, they do. For some people, it takes a long, long time. For some people, it goes away within 1 to 2 years.
Can you still have symptoms after menopause?
Yes,
Yeah.
put that with a caveat. Symptoms after like say that you go into menopause and you haven't had a period for 5 years, and you felt fine for 5 years, and now all of a sudden at the age of 55, 56, with no period for 5 years and feeling fine, now you're feeling with hot flashes and mood swings and all that. That the first thing needs to be happen is you can't just say, oh, it's menopause. There may be other reasons that these hot flashes are happening, and that needs to be worked up by your primary care provider. There are many reasons to have hot flashes other than menopause, other medical illnesses. So I don't want that to sort of like just be chalked up to say, oh, it's menopause, I'll just get over it. Like if you haven't had it initially and then you have it like much, much later, then something else is going on, probably.
Okay. Should we be taking vitamin D and calcium during menopause?
Absolutely. Vitamin D and calcium, what I usually do is um, there's like over the counter. It's CVS or Dwayne Reed. It's Oscal, which I love, but it's the generic part of it. Or Tums is actually the cheapest, and you can get generic Tums. I actually take some myself. They come in different flavors. You leave them on your desk. I actually ran out, but you can put them in like a little thing here. You put it on your desk, and they're like candy. That's why this is gone.
Could you still get period pain after menopause? I guess that means cramps.
Technically, no, but if you do, something else is going on, or, you know, I would wonder I would wonder why that's happening. The answer is yes, but it's probably not period cramps, and I would want to figure that out. So a lot of times, just to let you know, so you haven't had a period for a year, and all of a sudden you feel like you're having a period now, or there's some bleeding and you have like a period after a year. It can happen. You can have a period after a year. The body's kind of odd in that way, right? I mean, you can release an egg and cause a period. So it's not unusual.
Okay. As you get older, and you think you're becoming into menopause, does your period blood get darker?
It For some women, yes, but it's not like, oh, that's going to happen if you get older. Like it's not like a guarantee. So fibroid tumors are a very, very common, I'm not going to even say abnormality, because they're very, very common. They're much more common in African American women. They are overgrowth of muscle in the muscular layer of the uterus. What causes them? Um, so there is a predilection for some people to develop fibroids than other people. Who are these people? We don't know. Like, we don't know why does, you know, uh, Ms. So-and-so develop fibroids and Ms. So-and-so over there doesn't develop fibroids. But what we do know is it originates from one cell that grows, right? It's like, and so everyone says, oh my God, it's a tumor. Technically, it is, but it's a benign tumor. It's a benign tumor of the muscle layer of the uterus. So what makes it worse are estrogen. So who has estrogen? Young women or women of childbearing ages. So clearly, what happens is that you may have small fibroids earlier on in life. As estrogen develop, if you get more estrogen, they will grow. So like estrogen states that are very heavy. For example, pregnancy. So if you had a small fibroid, maybe like a fist, right? And now you're pregnant, lots of estrogen, it will grow in pregnancy. And then when you're not pregnant, it will shrink. Other states where you don't have a lot of estrogen, like menopause, um, it will shrink. So when do we get concerned when a fibroid can develop into a cancerous fibroid? Only 1% of all fibroids develop into cancer. And so for the most part, that's usually a rapidly growing fibroid, one single one, or a fibroid that grows in menopause when there isn't any estrogen.
What causes a cyst in your cervix?
The cyst in the cervix.
Yeah.
So those are what we call Nabothian cysts. Those are, again, benign cysts in the cervix, and usually they are related to patients who have had pregnancies in the past. So, or some kind of procedures in the past, or some kind of trauma to the uterus or cervix, like i.e., like I said, procedures, deliveries, things like that. So what happens is that there are glands on the cervix, okay? And it's sort of like glands on your face or glands anywhere. And they get irritated and they can produce what we call, and they can get blocked and fill up with mucus. And that's what it is. They're benign. They don't harm anything. They don't cause anything. They don't damage anything. They're not painful. They're just cysts. So that's what they're from.